Hi, I'm Sinead Bliss and I currently work for the Darling Downs South West Queensland Medicare Local. Today I'll be talking briefly about health literacy from an organisational perspective. I first became interested in health literacy when we were advised that this would be a major focus for our Medicare Local in this financial year, and my role description had changed to implement a health literacy project across our region. Unfortunately, we had significant changes in our budget as well as our staffing, and we did not receive the funding to roll out this project. However, we still see this as an important topic, which is why I'm presenting this today. As an organisation, we are also adopting this concept internally and working towards becoming a health literate organisation. There are various different definitions and interpretations about health literacy, but here is a summary of a few key points. Firstly, communicating health messages in ways that others can understand. There are three central components: the communication skills of the person expressing the message, the learning needs of each person receiving the message, and the complexity of the message itself. So it's really a shared responsibility between patients and providers, and both must communicate in ways that others can understand. At the individual level, health literacy is having the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. In 2006, a nationwide survey demonstrated that 3 in every 5 Australian adults have less than adequate levels of health literacy. The Adult Literacy and Life Skills Scale is what defines what I mean by below adequate. There are 5 different scales, but generally level 1 and 2 and level 4 and 5 are merged together when the data is presented. Level 1 and 2 is considered very limited health literacy proficiency and reflects approximately 20% of our population. Level 3 is considered to be the minimum proficiency standard and is often referred to as an adequate level. But keep in mind, although it is referred to as an adequate level, it's still the minimum level required. Lastly, level 4 and 5 refer to good and excellent proficiency, but this amounts to only 6% of our population. This pie chart makes it a lot clearer to visualise how the scale is broken down across the Australian population. You can see here that the red and pink categories indicate the low levels of health literacy, which as mentioned is about 60% of the population. And of the remaining 40% with adequate levels of health literacy, only 6% have high health literacy levels. With most things, there's always going to be a population that is at more at risk than others. This slide is referring to the percentage of adequate health literacy levels as opposed to below adequate, which we previously discussed, as this is just how the data was presented. So when we compare to the roughly 40% of Australian adults that have adequate levels of health literacy, we can see the populations that are at risk. Some examples include overseas-born Australians. It's not significantly lower, but it does drop to 27% for those who have arrived within the last 5 years. Additionally, when English is not the first language spoken, this drops to 26%. Those who have a socioeconomic disadvantage, not surprisingly, also have lower levels of health literacy. For those who are in the bottom 20%, which is the lowest quintile, only 26% have adequate levels of health literacy, as a comparison to the most advantaged in the highest quintile, where approximately 50% have adequate health literacy levels. And the last example is people aged between 65 to 75, which is significantly lower at only 17%. It's also worth noting that only 29% of adults aged 55 to 59 have adequate levels of health literacy, so age is definitely a risk factor. It's fairly obvious to assume that these figures aren't great, but why do we care, and what impact does this have on our health system? This will give you a quick run through of the many effects of health literacy. Moving on from the statistics now, there are arguments for and against screening patients individually to establish levels of health literacy. The main reason that encourages routinely assessing health literacy is that it may guide your choice of teaching methods and materials. However, the key point against assessing is that it may promote feelings of anxiety or shame for the patients. There are various red flags of communication problems to look out for that may provide an insight into a person's level of health literacy. Examples of informal ways to assess health literacy or red flags are probably indicators you are all very familiar with. These include consistently having headaches or always forgetting their glasses when asked to perform reading tasks, saying their hands hurt and asked to take their paperwork home, regularly asking others to read written materials aloud, identifying medications by appearance rather than reading prescription labels, and asking a lot of questions about topics already covered in handouts and brochures. As mentioned, people often have negative feelings and emotions related to their limited reading ability or general understanding, and may not openly disclose this. As a result, some coping techniques and other examples of red flags to look out for include inaccurate or incomplete forms filled in, frequently missed appointments, non-compliance with medication or treatment options, and the client says they are following instructions but tests and follow-ups indicate otherwise. The community has the right to understand healthcare information that is necessary to safely care for themselves and to choose among available alternatives. Therefore, we have a duty to provide information in simple, clear and plain language and to check that patients, clients or the general community have understood the information that has been presented. Studies have shown that among the general public, adults read on average about 5 grade levels lower than the last year of schooling that they did. So someone finishing in grade 12 could potentially be reading at about a grade 7 level. Increasing health literacy does not depend on the skills of individuals alone. It is a shared responsibility between health organisations and individuals in order to improve health outcomes. Therefore, system changes are needed to align healthcare demands better with the public's skills and abilities. So what is the health literate environment? The health literate environment is the infrastructure, policies, processes, materials and relationships that exist within the health system. These can determine how easy or difficult it is for consumers to navigate, understand and use health information and services, and to then make effective decisions and take appropriate action for their health and healthcare. This can include design and layout of hospitals, support groups for people with chronic diseases, and consumer education. It also includes the communication processes and relationships that exist between consumers and healthcare providers. For example, the use of shared decision making, the way information is tailored during consultations to meet the needs of the consumer, or checking that the information has been understood. Teachback is an example of a communication method for clinicians, also known as show me or closing the loop. This method is a way to confirm that you have explained to the patient what they need to know in a manner that the patient understands. A basic overview of this method is asking service users to repeat in their own words what they need to know or do in a non-shaming way. It is not testing service users, rather, it tests how well you explained a concept. Using Teachback provides an opportunity to check for understanding and, if necessary, reteach the information. Another way we can begin to reduce the gap between the health environment and an individual's ability to understand is to improve the readability of print material. This includes content in event flyers, brochures, education material, and websites. There are various tools available to assess the readability of documents. However, you shouldn't wholly rely on computer programs to assess readability levels. More than 100 factors impact on how readable a document is, such as sentence length, word choice, tone, layout, illustrations, etc. Readability formulas usually calculate based on the average number of words in sentences and the average number of syllables in the words. Although they are an imperfect or incomplete way to assess the readability of a document, they can be beneficial to use at the beginning and at the end to confirm that some improvements have been made. There are a number of other tools that can also be used to get some idea of how readable written material is. SMOG, or Simplified Measurement of Gobbledygook, and the Fry formula are tools that you can use by hand. They calculate a reading grade level by counting words with syllables. Smog counts all words with 3 or more syllables in the 10-sentence passage, whereas Fry looks at the number of syllables and sentences in 3 100-word passages. Assessing by hand helps you identify problem areas where a computer-based program will not. Many word processing programs include readability formulas within the spelling and grammar check tools. However, it may count all dots as periods that end sentences, or incorrectly count syllables based on spelling. If you are using a computer-based program, there are many programs designed specifically for this purpose. Helen Osborne recommends the following 2 programs: Readability Calculations or Readability Plus, and Readability Studio. There are various other methods of assessing readability, including checklists, such as SAM, which stands for Suitability of Assessment of Materials, or simply objectively and subjectively assessing strengths, weaknesses, and areas to revise, or using simple scales to rate content, design, organisation, language, tone, appearance, graphics, cultural appropriateness, and other criteria. Where possible, a great way to assess materials is with representatives from your target audience. This is an ideal option as it gives you feedback from fresh eyes and allows you to determine how readable your document is from the perspective of your target audience. It's important not to overinterpret the results, especially when assessing the reading grade level of your material. Readability tools are not always 100% accurate, and you can generally give or take 1.5 grade levels from your results. Results will also often vary between software, and just because you have less syllables in your material doesn't mean it's easier to understand. Clear and simple writing is the key. Focus on the information that the reader needs to know, and organise the information in a way that makes sense to the reader and is inviting to read.
Buckle down and work. Sheldon?
What?
I need an aspirin. Top desk drawer.
Thank you.
All right?
Yes, good.
Based on what I just discussed about readability and considering the population levels of health literacy, take a moment to think about how many people would find the information presented here helpful. This blurb is the information that was released on the WebMD about anthrax after the 2001 terrorist attacks in the US. It's very difficult to comprehend and to understand what a spore is, let alone what bacterium means. It makes you wonder how the public was supposed to use this information to understand how to protect themselves. This is an example of how policy information can be presented to clients in a way that is much easier to understand. Although there is actually more text in the second example, it's easier to read because it uses simple vocabulary and simple sentences instead of complex structures, repeats key phrases, and defines terms. Here is another before and after example of a letter sent to the parents of a new child. Not only is the revised version set out more clearly, but the content is much easier to understand, as well as feeling more personal, even though it's a standard template. The reading grade level has also changed from grade 12 to between grade 5 and 6. This slide is just a couple of light-hearted examples that aren't specifically health related, but they are good examples of how information presented can be misleading, misinterpreted, or simply confusing to understand.
There's a white guy in a hospital bed. He has an oxygen mask over his face. Nurse comes in. The patient talks to the nurse and says, "Are my testicles black?" The nurse gets shocked, uncovers a blanket and says, "I'll check." The patient takes off his mask and says, "I like what you're doing, but what I asked is, are my test results back?"
So in summary, there are 10 attributes of a health literate organisation. The first is it has the leadership that makes health literacy integral to its mission, structure and operations, such as developing and implementing policies and standards, and setting goals for health literacy improvement. Next, it integrates health literacy into planning, evaluation measures, patient safety and quality improvement, such as conducting health literacy organisational assessments. The third is that it prepares the workforce to be health literate and monitors progress, such as setting goals for training of staff at all levels. It also includes populations served in the design, implementation and evaluation of health information and services. A health literate organisation also meets the needs of populations with a range of health literacy skills while avoiding stigmatisation. It uses health literacy strategies in interpersonal communications and confirms understanding at all points of contact, such as the teach-back method, secures language assistance for speakers of languages other than English, limits to 2 to 3 messages at a time, and uses easily understood symbols in wayfinding signage. It also provides easy access to health information and services and navigation assistance. Designs and distributes print, audiovisual and social media content that is easy to understand and act upon, such as involving diverse audiences, including those with limited health literacy in development and rigorous user testing, and uses a quality translation process to produce materials in languages other than English. A health literate organisation addresses health literacy in high-risk situations, including care transitions and communications about medicines. For example, prioritises high-risk situations, such as informed consent for surgery and other invasive procedures, or emphasises high-risk topics, for example, conditions that require extensive self-management. And lastly, a health literate organisation communicates clearly what health plans cover and what individuals will have to pay for services. This concludes my introduction into organisational health literacy. If you have any specific questions or would simply like to discuss the topic with me further, please feel free to contact me on my details in the next slide. I am also more than happy to forward any of the resources or links that I have mentioned in this presentation.
Ta-da! 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 Ta-da!